This class is about antifungal drugs. So fungal infections can be divided broadly into these categories. So you have superficial mycosis, which affects hair and epidermis of the skin. For example, tinea versicolor, all tinea infections, and cutaneous mycosis, which affects skin and nail, mostly caused by dermatophytes. And you have subcutaneous mycosis, which affects the subcutaneous tissues like candidiasis, and systemic or deep mycosis, which affects the organs like lungs, lymphatics. For example, aspergillosis. So these are the common dermatophytes or ringworm infections. So you can see this is the typical clinical feature of dermatophyte. So you have the scaly lesion with demarcated margins, and the most common risk factors or immunocompromised state, extremes of age, diabetes mellitus, and chronic corticosteroid use. So depending upon the area affected, these tinea infections or dermatophytes or ringworm infections can be classified as tinea capitis when it affects the scalp region, tinea faciae, which when it affects the face, tinea barbarae if it affects the chin region, that is the beard region, and tinea corporis when it affects the body, tinea manum when it affects the hand, tinea unguum, ringworm infection of the nails, tinea cruris, which affects the inguinal region, and tinea pedis when it affects the foot. And this is another common fungal infection, candidiasis. So you have oropharyngeal candidiasis. So it can manifest as an oral thrush, or esophageal candidiasis, or vaginal candidiasis. These are the common fungal infection which we commonly see. The predisposing factors are mainly use of broad spectrum antibiotics, steroids, anti-cancer, immunosuppressant drugs, dentures, indwelling catheters and implants, and patients with AIDS. So antifungal drugs can be broadly classified into antibiotics, antimetabolites, azoles, allylamines, and topical agents. Antibiotics, you have amphotericin B, Nystatin, griseofulvin, and Echinocandins group of drugs. Antimetabolite, you have flucytosine. Azoles, these are the commonly used antifungal drugs now. So we have imidazoles and triazoles under azole category. And topical agents, we have few drugs, and allylamine, terbinafine. So this is the broader classification of antifungal drugs. So we'll see the important drugs one by one. Amphotericin B. So the important point you should remember about amphotericin B is it is a highly toxic drug. Okay, it is reserved only for severe fungal infections. So it has high affinity for ergosterol. So this is the fungal cell wall. So you can see the fungal cell wall constitutes proteins, beta glucans, and ergosterol. Okay, so these are ergosterol, and this amphotericin B binds with this ergosterol and it forms a micropore. So the amphotericin molecules, they bind together and they form a pore. Okay, so through which the substances inside the cell gets leaked outside. So the cell permeability is markedly increased, and which causes osmotic fragility and cell death. So here the important point you must remember is the selectivity of amphotericin B to the ergosterol is very low. That means it binds to mammalian mammalian cell wall ergosterol as well. So because of this poor selectivity, amphotericin B is associated with high toxicity. Okay, and it is fungicidal at higher concentration and static at lower concentration. The pharmacokinetic features of amphotericin B, it is not absorbed orally. So if at all it is given orally, then it has to be for oral or intestinal intestinal candidiasis, where the action is only local without systemic absorption. So mostly amphotericin B is administered as intravenous suspension. So it is available as a dry powder form in combination with deoxycholate. So this is the conventional form of amphotericin B. So you have to constitute the solution just before infusion. So it is a highly lipophilic drug, so it gets penetrated into all the tissues. It gets accumulated in all tissues, and the terminal half-life of amphotericin B is 15 days. It is 60% metabolized in the liver, and it's excreted both in urine and bile. So we saw that amphotericin B is a highly toxic drug. So when we give conventional amphotericin B, the patient would experience many acute adverse effects like infusion-related reactions and chronic adverse effects like nephrotoxicity and anemia because of the poor selectivity of the drug. So in order to reduce the toxicity and improve the tolerability, we use amphotericin B in a liposomal form. So this is a dosage formulation which decreases the toxicity of amphotericin B. So here we have, here we are incorporating amphotericin B into the liposomes, okay, so which consist of biodegradable phospholipids. So these liposomes are then again injected into the body. So the advantages of this liposomal formulation of amphotericin B is that it produces milder acute reaction. It has low nephrotoxicity, minimal anemia, and it delivers amphotericin B particularly to the reticuloendothelial cell of liver and spleen. So it is valuable in the management of diseases like Kala Azar and also in immunocompromised patients. Adverse effects of amphotericin B are acute or long term. So acute reaction. So during infusion, the patient may experience fever, chills, pain, or thrombophlebitis after infusion. Long term toxicity include nephrotoxicity, anemia, and CNS toxicity. Uses of amphotericin. It can be used topically for oral vaginal cutaneous candidiasis, fungal corneal ulcer. So this is a fungal corneal ulcer, and otomycosis, the fungal infection of ear, and all types of systemic mycosis. And actually, usually it is, though it can be used topically for the superficial infection, so it is reserved only for extreme or severe cases, because we usually prefer azole group of drugs for these type of infections. Okay, so it is mainly used for severe form of systemic mycosis, febrile neutropenia, and leishmaniasis. So you have to be careful with drugs which causes nephrotoxicity when given along with amphotericin B, because amphotericin is a highly nephrotoxic drug. So drugs like aminoglycosides, vancomycin and cyclosporine are nephrotoxic as well. So they produce dangerous renal impairment when given together. And flucytosine, an antifungal drug, when it is given along with amphotericin B, it has supra-additive action, because amphotericin B, it forms a microphore, and it improves the entry of this drug into the fungal cell wall and enhances its action. So it has a synergistic action. So that's all about amphotericin B. The next drug is Nystatin. Nystatin is used only locally, okay, for superficial candidiasis, monilial diarrhea, vaginitis, and oral thrush. So it is not used systemically for other infections. Another important group of drugs are echinocandins. So here, caspofungin is the prototype drug. Echinocandins, they inhibit the synthesis of the beta glucan. So beta glucan is an integral component of the fungal cell wall. So it inhibits the synthesis of beta glucan, thereby decreases the stability of the cell wall. It weakens the cell wall, which leads to osmotic susceptibility and cell death. It is not absorbed orally, caspofungin, and it is infused intravenously as freshly prepared solution. It is distributed into the tissue, but it does not enter the CSF, so it cannot be used to treat meningitis, fungal meningitis. Uses are especially for deep and invasive candidiasis and febrile neutropenia. So it is relatively a well tolerated drug because of high selectivity. So acute reactions include acute febrile reactions and phlebitis with IV infusion. Rashes, vomiting, dyspnea, hypokalemia, and joint pain may occur occasionally. So that's all about echinocandins. Then you have griseofulvin. Griseofulvin is a fungistatic drug. It is used only in the management of dermatophytes, that is superficial infection. Um, not caused by candida. Okay, so it is not active against candida. It is used in the management of dermatophytes, which is caused by other fungus, and it is not used in the management of deep mycosis. So the point you should remember about griseofulvin, it is used only in the treatment of dermatophytes. Mechanism, it interferes with the mitosis, so it produces multinucleated and stunted fungal hyphae, so thereby interferes with the cell division, and it binds to microtubule also, polymerized microtubules, and interferes with their function. So basically it interferes with the cell division of the fungus. The absorption of griseofulvin is improved with fatty food. So when you are taking the griseofulvin, the patient should be encouraged to take along with high fat food, and it is keratophilic. That means it has greater affinity for the keratin, so it gets deposited in skin, hair, and nails, and it induces CYP450 enzyme. So this is an important drug interaction point you should remember about griseofulvin. So it is an enzyme inducer. So drugs which gets metabolized by the same enzyme will be affected when griseofulvin is used along with it. So it induces the especially warfarin metabolism and oral contraceptives. The metabolism of OCPs are induced, so it can lead to OCP failure, or the anticoagulant effect of warfarin can be reduced. Griseofulvin is a well-tolerated drug. The headache is the most commonest adverse effect. Other than that, you have GIT disturbances, occasionally CNS symptoms and peripheral neuritis, and rashes, photoallergy, and hepatitis can occur. So in that case, you have to discontinue the drug. So as discussed, griseofulvin is used only for dermatophytosis. Okay, so this is the fungal infection of the nail and scalp, and it is ineffective topically. So though it is used for superficial fungal infection, but it cannot be used as a topical agent, so it has to be given orally only. So it is reserved for cases with large body surface involvement, onychomycosis, and tinea capitis, because for other ringworm infections we usually prefer azole group of drugs, clotrimazole, because it can be given as a topical agent. So only if the infection involves a very large surface body area or difficult infections like onychomycosis and tinea capitis, then you can use griseofulvin. The next drug is flucytosine. So this is an antimetabolite, pyrimidine antimetabolite. So this drug, it goes inside the fungal cell and it gets converted into 5-fluorouracil. So you all know 5-fluorouracil is an anti-cancer drug. But here this drug gets converted into 5-fluorouracil only inside the fungal cell. So it doesn't have any anti-cancer activity when it is for mammalian cell. Okay, against mammalian cell. So this 5-fluorouracil is then again converted into uridine monophosphate, which inhibits the thymidylate synthase enzyme. So thereby it inhibits the DNA synthesis. So it interferes with the DNA synthesis of the fungal cells, and it has very narrow spectrum action. It is fungistatic, so it is active against only specific fungi like Cryptococcus, Torula, Chromoblastomyces, and a very few strains of Candida. So it's a narrow spectrum fungistatic agent. Adverse effects, it causes dose dependent bone marrow depression and gastrointestinal disturbances. Mild reversible liver dysfunction can occur. So that's all about flucytosine. Now we are going to see the important, most commonly used group of antifungal drugs, the azoles, which consist of imidazoles and triazoles. So it is the most extensively used antifungal drugs. It has very broad spectrum antifungal activity. That means it is used for dermatophytes, it is used for mucosal candidiasis, it is used for systemic deep mycosis as well. It inhibits the mechanism is it inhibits this lanostirol 14 demethylase enzyme, which is involved in the conversion of lanostirol into ergosterol. So we all know ergosterol is an important constituent of fungal cell wall. So it interferes with the synthesis of ergosterol. And this lanosterol 14D methylase is a type of fungal cytochrome P450 enzyme, but this drug is this group of drugs are highly selective. It has very low affinity for mammalian enzymes. Mammalian CYP enzymes are not much affected, and hence the toxicity is also very less. Clotrimazole belongs to azole group of drugs. It is a topical imidazole. It is effective in the treatment of all tinea infections, automycosis, and oral cutaneous vaginal candidiasis, oropharyngeal candidiasis. So it is a topical imidazole group of drug. No systemic toxicity is seen after topical use. Ketoconazole, it was the first orally effective broad spectrum antifungal drug discovered, but because of its drug interactions and adverse effects, it is not commonly used. So other safer azole group of drugs are preferred nowadays. The oral absorption of ketoconazole is facilitated by gastric acidity. So that means when the gastric pH is low, the absorption is high. So whenever you give ketoconazole along with drugs like H2 blockers or proton pump inhibitors or antacids, which decreases the pH, which increases the pH, the absorption of ketoconazole is affected. And it has high extensive hepatic metabolism. Another important feature is it is an enzyme inhibitor. It inhibits cytochrome P450 enzymes, 3A4, 2C9, 2C19, all enzymes are inhibited. So because of this, many drugs like anti-epileptics, warfarin, anticoagulants, oral contraceptives. So many drugs, when it is given along with ketoconazole, the metabolism is inhibited and high toxicity can occur. Adverse effects are nausea, vomiting, loss of appetite, headache, paresthesia, rashes, and hair loss. The unique adverse effect of ketoconazole, you should remember, is it decreases the androgen production from the testes, displaces testosterone from the protein binding sites. So because of this, it can cause gynecomastia, loss of hair, loss of libido and oligozoospermia in males, and it causes suppression of estradiol synthesis, which may lead to menstrual irregularities in females. It also decrease serum hydrocortisone, by decreasing the synthesis in a dose-dependent manner. Users, as I said, because of the drug interactions and toxicity, it is not commonly used for systemic fungal infections. So it is commonly used as lotion or shampoo in the management of seborrhea of scalp and dandruff. It is also used in the treatment of pityriasis versicolor, a type of fungal infection which involves a limited area of the skin. When limited area of the skin is involved, ketoconazole can be used topically. The next azole group of drug is fluconazole. It is a water-soluble triazole. It is used in the management of many systemic mycosis, and it has high oral bioavailability. 94% of the drug is absorbed, so it can be given both by oral and IV route. And the oral bioavailability is not affected by food or gastric pH like that of other azole drugs, and it penetrates into CSF. So it is used in the management of fungal meningitis. This is an important point you should remember. So the picture is the CT scan image of cryptococcal meningitis. Itraconazole, it has a broader spectrum of activity. So it is active against aspergillus as well. It is fungistatic. Like any other azole, it is the absorption is enhanced by food and gastric acid. It is a highly protein-bound drug, large volume of distribution, and the CSF penetration is very poor, so it is not preferred in meningitis. Like any azole group of drugs, it inhibits the cytochrome 3A4 enzyme. Uses of itraconazole, it's mainly it is used in systemic mycosis, but not against, not for meningitis, because the CSF penetration is very poor. And it is a drug of choice for rare fungal infections like paracoccidiomycosis and chromomycosis. And other uses are vaginal candidiasis, chronic aspergillosis, dermatophytosis, onychomycosis, pityriasis versicolor. Adverse drug reactions or dizziness, pruritus, headache, and hypokalemia. After prolonged treatment, sometimes it may cause impaired left ventricular function. Voriconazole, it is the drug of choice for invasive aspergillosis. So this is the uh, Aspergillus pneumonia, and also in the management of disseminated infections by fluconazole resistant candida. So for invasive aspergillosis and resistant candidal infections, voriconazole can be used. It is also used for fusarium infections, febrile neutropenia, histoplasmosis, and blastomycosis, and it is also an enzyme inhibitor. So the adverse reactions of voriconazole or rashes, photosensitivity, rise in liver enzymes. It can cause QTC prolongation, and visual disturbances can occur after IV injection, which is short lasting. Posaconazole, it is the only azole which has efficacy in mucormycosis. And the adverse effects are nausea, abdominal pain, loose motions, headache, dizziness, and drowsiness. Absorption is improved by low pH and fatty food. It is metabolized by CYP2C19, but it inhibits CYP3A4 enzymes like other azoles. So this is the mucormycosis. That's all about azoles. Then we'll move on to terbinafine. So it is an orally and topically active drug against dermatophytes and candida infection. It is a fungicidal drug. The mechanism of action is it inhibits the squalene epoxidase enzyme, the first step in the synthesis of ergosterol. So here the squalene is converted into squalene epoxide, which again gets converted to lanosterol and ergosterol. So the terbinafine, it inhibits the first step of ergosterol synthesis. It has high first pass metabolism, widely distributed, highly plasma protein bound, and it has high affinity for keratin. That's why it is used in the treatment of dermatophytes. It does not inhibit CYP450 enzymes like your azoles. It doesn't have any drug interactions. So when it is given orally, it is usually well tolerated, no adverse effects seen. Topical use can be associated with erythema, itching, dryness, irritation, urticaria, and rashes. Uses mainly orally used for onychomycosis and tinea capitis. Topically, it is used in the management of tinea infections and pityriasis versicolor. Now, topical antifungals. So, we have certain antifungal agents which are exclusively used topically for the management of dermatophytosis. So, we have tolnaftate used in the management of tinea cruris and corporis. Cyclopyroxolamine used in the management of tinea infections, pityriasis versicolor, and dermal candidiasis. So it is available as a nail lacquer. That means like nail polish, it can be applied in the management of onychomycosis. Butynaphine, it is a congener of terbinafine, which is used topically. Anticyclinic acid used in the management of tinea infections, nappy rash, tinea cruris. Benzoic acid, it is a component of Whitfield ointment. It is used along with salicylic acid in the treatment of fungal infections, the hyperkeratotic regions. Okay, so since the salicylic acid is a keratolytic agent, this combination is used in the hyperkeratotic lesions. Okay, so that's all about antifungal drugs. So the main points you should remember about antifungal drugs are, so fungal infections can be superficial or deep. Okay, so for superficial fungal infections, most common drugs used are azoles, topical azoles like clotrimazole. Okay, if the superficial infections are not manageable by these topical azoles, then you can go for oral griseofulvin. And for deep infections, you have many drugs. So again, azoles are preferred because of the low adverse toxic profile. And amphotericin B can be used for severe infections. So when we are using amphotericin B, we have to watch for the nephrotoxicity and infusion related reactions. So it can be prevented or minimized by using liposomal amphotericin B formulation. Okay, then you have certain topical antifungal agents. So yeah, the drug interactions are important when you are using azole group of drugs, so especially ketoconazole and other drugs. So griseofulvin is an enzyme inducer, whereas azole group of drugs are enzyme inhibitor. So the drug interactions should be remembered when you are giving these group of drugs along with other drugs like anti-epileptics or anticoagulants. And so the most common predisposing factors for fungal infections is the immunocompromised state. Okay, so these are the points you should remember about antifungal drugs. Thank you.